يا هلا يا هلا، حياك. مهلي، هلا معلاوي، مس النور، هلا دكتور، هلا بالغالي، لايك شلون حبيبي، هلا والله. يا هلا دكتور كاظم حبيبي، هلا منور، مس النور، هلا بحمودي، هلا بليوث، هلا بالغالي، هلا بالسوف، مشتاقين حبيبي. اوكي، وعليكم السلام. يلا ننتظر سدير. We are waiting for سدير and توماسو. نتلكك حبيبي ليوث قلبي. اوكي، هيكون اللايف as we mentioned before, it's two parts. The first part is going to be by Sadir. It's going to be only about vertical preparation, you know, crown vertical preparation, because now we almost stopped, or we're less using. Oh wait, welcome to Iraq. Wait a little bit. هسه علي لك صوت، بس خلي ترجع لنا الكهرباء العظيمة. العراق العظيم. Okay, yeah, back again. Okay, yeah.
Hello.
هذا حبيبي، هذا بسدور.
Hello. Hello everyone. Hello. الصيني بدك دا أشوف صوتك. أنت يمي أطلع بس.
Now I'm back. I think I'm back, right?
Okay.
علي معين الغالي. اشتراك. We are waiting for Tommaso also to join us. Where is there's Tommaso.
Hey guys.
Hello. Hey Tommaso.
How are you?
I'm good, my friend. How are you? How is everything?
Very fine, very fine. Thank you.
Thank you.
Very busy week, but now we are ready. How are you?
Thank you. Thank you for joining us, man. Thank you for accepting my invitation.
Thank you too for invitation. Thank you. Hi,
Thanks.
Sadir.
It's our pleasure. It's our pleasure, man. It's our pleasure.
Can you hear me?
Yes.
What?
Hello, Tommaso. How are you?
Very fine, and you?
I'm good, thank you.
Super. Are you ready?
I'm glad. Yes.
I'm glad that you are both here, guys. I'm a fan of you, of two of you, really. Sadir here is one of my team. He's one of the partners at Late Team Clinics, okay? My team in Baghdad. He's doing almost everything like we always do, but he's mainly focusing on vertical preparation from now on, because as you know, like it's less complications. If you know how to do it, it's less complication. So I feel like it's mandatory for everyone to know it. And the other part of our live webinar is going to be by you, our friend Tommaso. I invite you not because just you are very skilled, also because I like you as a person. You are a very great friend.
Thank you.
So Tommaso is a very skillful person, as a very great person also. He's gonna share us like how he do his overlays, onlays preparation. He's do it in a very, very neat way. I feel jealous when I always see his preps as, oh, this is preps I need to learn. So today also Tommaso will share us this part. So Sadir will start his first part. Okay. It's gonna be about 25 minutes to 30 minutes. Then after that, the second part is gonna be for the genius Tommaso. Okay.
Perfect. So
it's gonna be about 1 hour and something for the total. Okay. But we hope that we give our best to the colleagues here, and that's it. Tommaso, Now we
Bye
will
bye.
Sadir
Yeah.
to
See you
start.
later.
Join us when Sadir finish, okay?
Yes. Thank you.
Habibi.
Habibi.
Okay.
Okay, Mr. Sadir. You are
So, can I start now? Let me
Yes.
just adjust my camera. In the beginning, guys, because we have like one audience, I'm going to talk in English. And for this webinar, I will talk about the essential part of vertical preparation, because in about 25 minutes, it's impossible to talk about all the criteria of that technique. So I'll talk about three parts: the easiness of the technique, and the biomechanic, and the soft tissue. So let's begin. Let me just adjust the camera.
Yeah, perfect. It's perfect now.
It's good?
Perfect.
Okay. Talking about vertical preparation, it's really not a new technique, but it started to be interested in 2017 when those two guys, Maialino and Vinotti, introduced the so-called butt bear. This is the butt bear we always talk about. It's just like a chamfer bear, but have a blunt end, smooth part, just like a thermal cut. So let's see the way this burr work on the tooth. You can see that this smooth part is inserted inside the sulcus, and the active part will work on the tooth, and by this way we can produce a perfect vertical wall. And if we compare this burr to the old one, the flame burr, it's always like a slight chamfer, because the shape, this is the profile of the flame bear. And with the flame bear, if you tilt the bear a little bit, you can easily get a mistake, because you have active part and can result in double line or scratching the cementum. While in the butt bear, because it's have like a safe end, if you accidentally tilt the bear, you can't do nothing, because the end of the bear is blunt and it will be in contact with the tooth structure, so no cutting will be on the tooth. Okay, let's see how that burr work in the oral cavity. This is the way the burr will work. You should insert the blunt end inside the sulcus, and you can see if you tilt the burr, you can't do nothing, because it's have a safe end. You should align the burr within the long axis of the adjacent tooth, and you start drilling. You should keep attention that all the blunt end, all the soft part of the tissue should be inside the sulcus, and you should also be careful about the long axis of the burr, and not to insert the active part too much inside the soft tissue. Only 0.5 billion to ensure equigingival or slightly subgingival margin. And this is the kind of preparation you're gonna get easily. This is like, I didn't skip anything. This is the real time of the video. You can see how easy it is. And you can see this is the type. I don't know if the images have good quality, but I hope you can see these margins that I can produce with that preparation more clearly on the vocal side. This is the margin we always talk about. This is the edge. This is the shoulderless preparation, where the crown will stop on these edges. Okay? This is the first. Okay.
I will interrupt you a few moments, please. So my question is, when you put your blunt end bear, when you put it inside the sulcus and you start to prep, you don't press too much.
No, you don't need to press. You just need to adjust, because if you press, you can't cut. Because when you press, the blunt end, the safe end of the burr, will be in contact with the tooth structure. So you just need to tilt, not press.
Okay, you don't push it too much inside the sulcus. You just feel a little pressure.
This is very important. You should be careful about that, because if you press too much, your margin, your edge will be very deep.
Okay, got you. So without extra pressure, put it inside the sulcus and go around.
Just tilt, don't press.
Okay. Okay.
Okay, so this is the first part. This is the easiness, the versatility, and practicality of the technique. And I want to apply that easiness, that versatility in most annoying part in restorative dentistry, which is the deep margin extension or deep margin elevation. And for people who are familiar with this technique, we know that the most annoying part of deep margin extension is the mattress selection, mattress adaptation, and the wedging, how to get a perfect seal. Okay, you have to get a perfect seal in order to elevate these deep margins. While in the vertical preparation, all these mattresses are not required. So let's see how does that work. Let's make a scenario where we have a very deep margin, like a equigingival or slightly subgingival margin, and we need to elevate it. Okay, guys, you should be careful that this technique you can apply it only if the tooth will need a crown in the complete coverage. If you don't need a crown, if it's only a filling, this is not going to work. Okay, so let's suppose that this tooth is heavily compromised tooth, and we need to do a crown over it. So this is the way I elevate the deep margins with vertical preparation, with the Verti technique. After cleaning the cavity, placing the rubber dam, do our etching and bonding protocol. All you're going to need now, no mattress, just filling. And don't care about the overhang, because all that overhang or irregular build-up will be eliminated by the butt burr. And this is the type of preparation you're going to produce, very smooth lines. I will show you in more details when I show some cases. So this is a case, very deep margins, a heavily disruptive case. Okay, it's restorable. I have good form. And after isolation, you can see this is my build-up. Very irregular, random build-up with overhangs and sharp edges. But after my preparation, all it gets smooth, because by the burrs, by the active part of the burr, I can remove all the excess, and my tooth structure is protected by the safe end. The blunt part, the smooth part, will take the tooth as a guide and only remove the excess and the overhang. Okay, so this is the easiness of vertical preparation in cases like deep margin elevation. Let's apply this technique on some clinical cases. You can see, like this case, I have broken buccal wall, very deep margins involving in the bifurcation area, and the second molar also I have a large filling, and this is endodontically treated tooth, so I'm going to do a crown over it also. From the buccal view, you can see I have some abrasion on the cervical part. These are undercut and also should be closed before starting the preparation. So what I'm going to need in this case, only isolation. I use subgingival clamps to get visibility on this bifurcation area. After that, I removed all the filling and packed Teflon to get a perfect seal. And I want you guys to imagine with me that after all that effort, after these subgingival clamps and putting that Teflon, you will insert a mattress. Of course, you will break the seal, and what type of mattress you're going to place in that very deep distal margin and in that bifurcation. So with the vertical technique, we don't use any mattresses. After isolation, you just need to do your bonding protocol and apply your filling, flowable filling directly on the margins, on the Teflon, and on the rubber dam. You can use any type of flowable. I don't care about that. Here I use the injectable one from GC because I have a good viscosity, so I have more control on it. And the reason why I don't care about the type of flowable composite, because most of it will be removed by the preparation. You should take more care in the type of core you use. Okay, so this is what I get after the build-up. Very random build-up with a lot of overhangs. And after the preparation, I removed all the overhang with my vertical preparation. Also, I did a vertebrae on the second molar, and the case has done. Also, I took a scan for fabricating a temporary, and you can see how easy it is to do like very deep margins with just about 1 hour and a half. Okay. Another case, same scenario, first and second premolar with very deep margins. Like look at the bifurcation, how difficult it is. I have the screw on the first molar. I didn't remove it. I have a good endodontic treatment. I just need to repair that old composite. After build up, I did my preparation, and this is after like 2 weeks. You can see the healing of the tissue. I packed some Teflon, took my scanner, and this is the final result. And I hope to see the follow-up and share it with you in the next week. Another case, very deep margins. You can see how deep it is in the second premolar. And sometimes rubber dam is not enough because you can see some bleeding and some leakage. You always need to pack some Teflon to get access to the deep margins. And after packing the Teflon, I can do my bonding protocol, elevating the margins with just a flowable composite and drill all that excess very easily in a controllable way. And after that, I did another isolation and completed my endodontic treatment. And you can see that with this technique nowadays, I can easily treat these deep margins without any effort. And because the most difficult part in deep margin elevation is the matricing. And when you get rid of the matricing, everything can become easy. So that was the first part. Let's talk about the second part, which is how biomechanically engineered this vertical technique, because this is a success key. If you have a good build-up, if you have a good tissue, but you have a poorly engineered technique, you're gonna fail. So this is the success key in our work. When we're talking about biomechanics in full coverage, of course, we should take care of the ferrule effect. This is the main issue. And what is the ferrule? Let's know how to see how the ferrule work. You can see that the ferrule under occlusion, it's make the whole structure as one unit. It's protect the crown and protect the root from getting fracture under the occlusal load. So this is the most important part of the tooth to decide that this is a restorable tooth. Okay, ferrule effect or the pericervical dentine. So what type of ferrule should I have in order to say that this is a restorable tooth? In general, it should be like 1.5 to 2 millimeter height and also 1.5 to 2 millimeter width. And when we decide that I have this measurement, this tooth is restorable, when I'm going to the traditional horizontal preparation, unfortunately, I place my margins on the most important part of the tooth and converting a restorable tooth, a good ferrule, into a weak ferrule by placing my margins on the ferrule. You can see I have reduced the thickness of the ferrule from 2 mm to only 1 mm with a 1 mm horizontal preparation. Okay, so take care. Look how it's different with the vertical one. Look how much tooth structure you can preserve with doing a vertical preparation, because most of the preparation is more coronally. On the ferrule, on the pericervical dentine, you just need to place a small margin where the crown will stop. Okay, so you can see how much there's a much difference between the amount of reduction you would do in horizontal and in a vertical one. So also the development of zirconia, we have the monolithic zirconia, which can withstand a minimal thickness of 0.4 or 2.6 thickness on the axial wall, and in the margin you can go out to 0.2 millim. Okay, and in the junction between the axial and the occlusal part, you should go to up to 1 million. That's why we do the reverse shoulder. You can see in the buccal part. So you can see in this photo how conservative this is. I did this prep on that tooth. This is a case of full mouth rehab. We did increase the vertical dimension, so I don't need much preparation. This is unedited work. Okay, so you can see all my prep still within enamel. You can see in these X-rays all my proximal surfaces is still within enamel. To be fair, I don't really care about enamel here because I don't do bonding. I always work with zirconia. I cement zirconia. But the idea here is to know how conservative it is. All the products are with an enamel, and if you're going to do some bondable coverage like lithium disilicate, you can use that enamel for great bonding. So that was the second part of the webinar, and the third part is about soft tissue stability. And I expect a question from you, which is why we vertic guys always talk about soft tissue stability, because with the horizontal one, and we can see with many cases, we have a very good soft tissue stability. The idea is that in the past, because of the over-contoured crowns in the past, there was some speech about like that crown will result in soft tissue irritation and soft tissue recession because there is no margin where the crown will end. They think like you will get like an overhang. But when this technique, when Ignacio Loy introduced the POPT technique, he used like a huge emergency profile, like a huge crown. You can see how much the red lines, how much thickness we have on the cervical part. And with this technique, they can get a very good healing. Look at these photos after 2 years or 5 years, very good soft tissue healing, and despite the wide emergency profile of the crowns, of course, to hide the metal ceramic, the metal part of the crown in that years, where zirconia was still under developing. I didn't use it orally. So I will show you that case that I've shared with you in a story, and I asked you about the type of the crowns they use in this case, and most of the responses were about, I know you can't see it, but most of the responses were about this is zirconia, this is feldspathics, some said this is natural. In fact, these are PFM crowns. They're done in the POPT technique, and you can see the type of soft tissue healing they get. So when you say a vertical perforation, don't care about soft tissue because it's going to be a very good one and you have a very good healing. In this study they did by Rex and Graham, they studied the type of soft tissue healing after the vertical perforation, and they figure out that you will have a very good soft tissue healing with complete connective tissue generation in about 21 days. So after doing a very deep preparation, you should wait from 2 to 3 weeks until so you can get a very good tissue healing to do your impression or scan. And this is the gingy tag. This is the cutting of the tissue around the vertical perforation done by the blunt end of the burr. And this cut also make the impression very easy, make the scan very easy because it's open a space like a window where the scanner can easily enter. This is the same case I talk about in the deep margin elevation. You can see this is after only 2 days, the type of soft tissue healing. In this case, I did a temporary provisional because this is ageless preparation and I should wait from 2 to 3 weeks. And this is a long time to keep teeth without a provisional. Not for the soft tissue, it's only fixation for the tooth. Okay, so you can see all my provisional far away from the tissue, about 1 to 2 millimeters, especially on the proximal, because you have to keep more space for the papilla, more than buccally and lingually. You should take care about that when you fabricate your provisional, okay? And especially in cases and when you do very deep cutting, like when you elevate a flap, you should wait more. This is after 45 days. And even after 45 days, I always place my crown equigingival or slightly supra. Why? Because cutting the tissue to this level will take more time to heal. So this is after 1 year. You can see how my margins all goes subgingival because what you get after 4 to 5 days in these cases is only the junctional epithelium and connective tissue healing. There is no sulcus or slightly a minimal sulcus. After about 6 months to 1 year, you can expect to the sulcus to regrow. That's why you should limit your crown only equigingival or slightly subgingival, like 0.5, not more than 0.5. Okay. In cases I do a slight preparation, like the shoulderless, I don't do provisional. I stabilize teeth only with liquidum, and also you should take care that your liquidum should not be over the tissue. You should always keep space between the stabilized liquidum and the spatula and the soft tissue to give some space for the tissue to regrowth. But in these cases, you should tell the patient to take care not to get food impaction beneath that liquidum, because it will compromise your soft tissue healing. This is the tissue healing after 1 week, and this is the crown. You can see the relation between the crown and the soft tissue, the type of the soft tissue, the stippling of the healthy tissue, and this is after 6 months. Okay. At the end, you should take care, because I see this mistake many times in the lab and in social media cases. When you do your crown for the vertical preparation, you should take care about the proximal part of the crown. This is a crown fabricated for a vertebrae. And you can see the problem here is that the level of the proximal margins almost equal to the level of the buccal and lingual. And this is a big mistake. If you keep that level and you cement or bond that crown, you should expect biological invasion. Because that crown, you should remove all this part, the red part. You should recreate the relation of cemento-enamel junction, the relation of enamel with the root. This is crucial. This is very important, because if you didn't do this part, if you did not notify your lab about this part, and you extend your proximal surfaces, just like in the buccal and in the lingual, you should probably expect a biological invasion by the time. Okay. So at the end, I like to resemble the vertical preparation with this tool, the multi-tool, because with this tool you have a scissor, you have a knife, you have a bottle opener, and you have the easiness, okay, to do anything you want. And this is the good part of vertical preparation, because you can do many things. You can prep, you can treat some gingival margins, you can have a very good soft tissue, and you can fabricate your crown biomechanically very good. Okay, so, but because I'm a man of indications and I love indication-driven dentistry, I don't do, if I have a very good tooth structure, of course I would not do any vertical preparation or a complete coverage. All these cases you can see here, I have a good enamel, I have a good dentine, and the way I treat these teeth, of course, are partially. I do like a partial coverage, inlay, onlay, and this is the part that's going to be presented by my friend Tommaso. This is the end, and if you have any question, you can ask me, or you can send me a message to my account. You can see all the cases I've shared with you in all steps. I hope you guys find this webinar useful for you. And because I have a limited time, I can't talk much more about that technique, because it's some kind of new technique for most of us. It's not new, but we don't use to it. We don't study it. So if you have any question, do not hesitate to send me. And to Hassan, I'm done. Okay, thank you guys. Thank you.
I have a lot of questions for you, but let's wait Tommaso. Thank you.
I'm ready. Okay. So we're gonna stay. I'm going to stay after Tommaso to answer some questions.
Tommaso, join us, please. And before he joins us, I have some few questions that I have read in the comments. First, one of them, like, what type of cement to use?
Well, it's according to the crown type. If I'm going to use zirconia, I always go with GIC.
Right.
Yeah, GIC GIC or resin modified GIC. I'm going to use Emax, of course. I'm going to go with bonding, like resin cement.
Emax is a little bit risky in the bonding in the subgingival area in such a case, right?
Honestly, it is easier with vertical preparation than with horizontal because there is much less gap. There's much less space for the resin cement. So when the excess come out, there's a little space of connection of the excess to the two structures. So you can remove that excess more easily if you compare it to the horizontal one. But of course, you have to pay some attention to remove all the excess. And that's why, again, with multiple reasons, I use the resin modified GIC with zirconia. I don't see any added value of using resin cement with zirconia, even after treating the zirconia.
Okay. Okay. Thank you. I have a lot of questions, and there's some question also, but we will leave it to the last. Okay.
Okay.
Until you both got finished, and I will come back to you. So the guys with the question, please wait till the end. We'll come back to the question and discussion parts because I have a lot also on my mind. Thank you so much, Sadir.
Okay.
Thank you.
Okay. Welcome.
So, join us at the end, okay?
Okay. Okay.
Okay, Habibi.
Bye-bye.
Bye-bye, bro.
Hey, bro.
Elevate,
Can you hear me?
elevate. Yeah, I can hear you very well.
Okay, yes.
Crystal clear, bro. Elevate,
Yes.
elevate.
Help me
Yeah.
to correct this mirror. Wait.
Okay, perfect.
Like this is good?
Yeah, it's perfect. Yes, it's perfect. It's perfect.
Good.
So,
So we
Tommaso,
can
you start.
yes,
Thank you
we can
again for
start.
accepting invitation. Okay, thank you so much. I really appreciate your time.
Yes, thank you too for invitation, Hassan.
Thank
Hello,
you.
everybody.
So, go ahead,
And
bro.
okay, thank you. Little presentation. I'm Dr. Brunelli. Hello, everybody. I live in Italy, in Bergamo, close to Milan. I'm a Style Italiano active member since 2018, and I'm passionate about restoration. After 8 years of works, after my graduation in 2016, today I dedicate myself to prosthesis, surgery, and orthodontist, but every time I put the dam and I relax, and I love my job. So Dr. Hassan knows that I love the indirect work, so thanks for this opportunity to show my work, my cases. You believe in me and a lot, and I'm grateful to you. Thank you. With this webinar, I want to explain and share with you what I always do in my office every day. And thanks, Dr. Sadir, for your presentation. You have shown an alternative way to restore and protect posterior teeth, I think. But if the enamel is present also in little portion, which technique we can use? Wait a moment. My screen is. Okay, sorry.
Okay.
Can you hear me? Okay.
Yeah, I can hear you very well.
Okay, so you know that today everything can be done. So we can decide to make inlays, overlays, or we can cover the cusps directly. But we want to see predictable protocols. So we all want our works to last over time. And I want to share with you simple and repeatable protocols by showing some clinical cases. In a case like this, for example, we had to decide where we can go direct and where we can go indirect. So if we want to make a hypothesis by looking at the picture, maybe we can do direct for premolars and indirect for molars. But before starting to do anything, I isolate the field with rubber dam. And after that, that, I remove the amalgam restorations, and at this point I can evaluate the teeth. So after cleaning, about the premolars, we can go direct, I think. Just second-class restoration, distal and mesial ones. About the molars, I think we can see a lot of fractures and cracks under the cusps. So for this reason, I decide to think indirect for these two molars. In the first appointment, I performed the direct restoration and the build-up for the molars one, and every step, of course, with a good and stable isolation. Never make a compromise, I think. If I have to trust my build-up in order to cement my overlay, I need to use the dam always, especially in the posterior teeth where the control of humidity, saliva, and bleeding is more difficult. In this case, I take a digital impression with the scanner that asks the use of the powder, and quickly we can see the phases of cementation, so etching, rinse, and bonding. About both molars, we have a complete enamel adhesion except the mesial margins. So here we have a stable composite. This is a control after cementation, and we can see a good mimetic work about the color too. In fact, if with the dam the tooth appears whiter, it is good. And with this lateral view, we can see the margin elevation with white composite, stable and polished. When I do a deep margin elevation, I always use a composite with a different color. In this way, I can always see where are my overlay and where are my elevation, especially during the polishing step. And this is the occlusal check and the contact point control. And this is another case where we have to analyze the situation and decide where we can go direct and when we can go indirect. And like before, we isolate the field with rubber dam, put the wedges, remove the old restorations, and analyze the situation based on the thickness of the cusps. So whether it is a vital or devitalized tooth, if I have healthy, beautiful, hard enamel, I use it to restore with an adhesive overlay or only. This is my opinion. And this is the post-cementation control. So 2 direct restoration for premolars and 2 indirect restoration for molars. And in a case like this, for example, first thing I thought was I have to devitalize the tooth and then cover it with a crown. But pay attention, because let's do like before, start with the isolation and clean the cavity. And the isolation is important because of the adhesion, but also because the dam can crushes the tissue apically, and cleaning is easier without bleeding. So this is one of the advantages of using the dam. It can retract the tissue and increase the view. So really, nothing is the same as before with the dam, I think. In this case, with the dam and an additional hook, we can reach the healthy margin. And one of the limits of horizontal preparation, I think, is being able to give to the technician the adequate space so that he can create a correct emergency profile. And also with the adjacent teeth, sometimes we must have to correct the space to can obtain the optimal contact points. For example, like in this case with a disc. And digital impression later then help you to analyze the situation about the visibility of the preparation of the margin, about the insertion axis and contact points. And again, obviously, the advantages of horizontal preparation is that it is really difficult to get the margin wrong. So the dental technician cannot make a mistake looking at our preparation, because it's easy to see when the inclination changes. So this is before and after cementation. And I know it's not a perfect case, maybe, but it's a borderline case. But the result is a complete cusp coverage in a vital tooth with an horizontal prep. So we always do an X-ray after cementation, especially in cases like this, where the risk to leave composite under the margin is high because of the depth of the margin. And this is the occlusal check after a few weeks. And step by step, we move on to the more complex cases, again, a single tooth, in order to be able to evaluate the technique better. So occlusally, you can see two different composites in this case, with a carious lesion and a crack in the distal part. The distal buccal and distal lingual cusps are very thin, while the mesial lingual cusp is totally absent. The tooth is beautiful, and it is well preserved vestibularly, and has a good chromatic integrity, I think. So in a case like this, I like to think to preserve all the integrity tissue. The assessment of healthy tissue is always done with the dam, like before, in position, so that a build-up or deep margin elevation can be performed, if necessary, in a clean and decontaminated environment, decontaminated field. In this case, after removing the carious tissue, we use a new composite and perform the preparation with anatomical reduction of the occlusal side, the interproximal boxes, and the inclined planes on the buccal and lingual sides. In this case, the digital impression is taken with the dam to avoid having problems with the blood. So another reason why I often take the impression with the dam is the following. So if I read the margin of the impression, it means that I will not have problems to do an adhesive cementation with the dam the next time. It often happens without a dam that you can see the juxta-gingival margin with the retraction wires inserted, but we don't know if it will be simple or a challenge to isolate the operating field during the cementation phase. So if you work with the dam for the impression too, it's for sure that you can do everything later. Again, in horizontal preparation, an horizontal margin cannot be read incorrectly. So you can see very well the line, and the dental technician too can see the line. And I always test the overlay before cementation, both without a dam and with a dam, to understand if I will need to use wedges or matrices to cement it. After applying the adhesive, we proceed with the cementation and final polymerization with glycerin gel to convert all the composite, and the final check with the dam and the occlusal check. And this is a picture after 6 months. You can see that the situation is stable. I know I always think horizontally. I think even in the strangest cases, I like to preserve enamel if I still have some of it available. So in this case, I have an incorrectly asymptomatic devitalized element with a distal drainage in this area here. And this is the X-ray and CBCT. You can see a large bone defect in the mesial root and in the distal root with the drainage on the occlusal side, as we have seen before. This is the video from CBCT to look at the defect. And I always isolate the element, and after removing all the restoration, I can evaluate the condition of the element. So I see that the distal healthy tissue is present and is soluble, and the root canal was poorly managed. So cleaning the chamber, we find an area of a lingual perforation, which had been managed with the gutta perca. And even if there is a little healthy distal enamel, there is still the present to guarantee an optimal adhesion, in my opinion. So keeping the dam in position, I've closed the perforation adhesively with a white composite to then to be able to polish it from the lingual side in next step. The etching part, bonding, and the white composite in position. And after having sealed the perforation, I managed the distal wall and the endodontic retreatment by cleaning the canals, removing the whole gutta perca. And here you can see the closure of the canal system with bioceramic and gutta perca. And this is a sequence of endodontic treatment. So the preoperative X-ray, the working lamp X-ray, and the seal. And here we can see the preparation of the distal canal for the positioning of the post, useful for guaranteeing the stability to the distal wall. This is a picture from camera, sorry, not from a microscope. And then I have rebuilt the element with the post and performed a composite restoration before managing an horizontal preparation with the dummy position, like before, to ensure the possibility of adhesive cementation. And now, to simplify, the preparation is performed with one burr. So first step, the occlusal reduction is completely horizontal. As you can see in this lateral view, the preparation is completely flat. And then the same bar designs the interproximal box with the horizontal preparation, in this case, just in the mesial side, where there is the adjacent tooth. And finally, on the left, the red ring burr for polishing, and the preparation is done. This is the situation before the cementation. As we said before, horizontal preparation holds no surprises, I think. So the dental technician's reading of the margin is unique, so without mistakes. And when I try the overlay, I'm always satisfied. So this is the final preparation, and you can see that the overlay has a good fit with tooth. The etching is only applied on the residual enamel because the composite is sandblasted, and I then use a universal adhesive system, and I distribute it over the element, brushing for 20 seconds. I then treat the overlay, etching on the lithium disilicate, and application of bonding and sealant. I proceed with the cementation with a warm composite. I love composite to do this because it fills any gap if they are present, of course, and because I have the time to remove it without risk of composite goes hard. So I can take 30 seconds, I can take 1 minute, I can do it in relaxed mode. So I love it. And after removing this excess, I cure it and polish with dedicated rubbers and burrs. And this is the control after 3 months, pictures, of course, and X-ray. So we see almost completely bone healing after 3 months. And now let's talk about the preparation, just a few minutes more. We have seen before using a few burrs, so the protocol is to be simple, thanks to Angelo and Walter and the Style Italiano team, not too many phases, but not too many burrs. So let's check together this case. This is a perfect case, I think, to understand this simple technique. The patient has high sensibility on the 3.6 because of the hold restoration exposes the dentin in this part. Again, digital impression before starting to save the situation. And we isolate the field with the rubber dam. I insert the wedges and start cleaning by removing the old fillings in the middle of the tooth. So now, partial or total cusp coverage, the question is, and the literature help us to analyze the residual tooth structure. So this study says that the endocavity alone causes a 5% loss of resistance in tooth, while the loss of one or both marginal walls causes 46 and 63% decrease in resistance. So don't worry just about vital or no vital tooth, but look at the structure too. Pay attention. So in this case, evaluating the residual thickness, the vestibular part appears to be too thin, in my opinion. So the vestibular part is very thin. The interproximal part, you lose the walls for the boxes and for the carriers too. So cusps coverage must be planned, I think. Again, like before, the first step, so with the burn number 1, is to perform an occlusal reduction with performing a flat preparation. And this is a result, so flat preparation. You can see at this point that what needs to be done are the interproximal boxes, which will remove the carious tissue present too. And the boxes are usually used to stabilize the overlay and to recreate a correct contact point between teeth and to remove the decay that is often present in these areas. So the boxes are usually okay. With the same drill, I open the interproximal boxes, and this is the view from above. As you can see, the preparation is done. One drill, so 2 inclination, a few minutes. Simple and mainly is easy to imprint. The last step is to polish with the second drill, the red ring 1. And here is our preparation. So simple with open margins that adapts perfectly to the digital impression and to the cementation using warm composite, like said before. The digital impression with the dam is in position, and the etching is on enamel, and then the universal adhesive is spread on the tooth and of the overlay, of course. And the heated composite is sprayed with spatula, trying to apply a uniform thickness, mainly on the interproximal boxes. After placing the overlay in the correct position, you have to remove the excess and cure. And this is the result after removing rubber dam. And here the result after 4 weeks, check the occlusion and after gum healing. And lastly, to show how the concept of deep margin elevation and adhesive cementation of the overlay can be pushed, of course. If I can elevate the margins by isolating with the dam, I can and I want to trust that relocation, because I strongly trust adhesion. So after deep margin elevation and endodontic retreatment, of course, I made a build up with the post and I do the preparation. I use the enamel available, in this case, less than 50%. Digital impression of the flat preparation, like before cases, and fit check fit check, no stress about the fitting and precision, thanks to the horizontal preparation and of course to dental technician. Etching on enamel and sandblasting on composite. This is the phase overlays preparation, and cementation with keeping out the composite, the excess composite with fissura. This is the final check, and
Very nice.
and where the deep margin elevation finishes. So the works you have seen were carried out in the office for which I collaborate, of course. I have often taken a risk because if I don't manage an overlay, for example, I develop this ability to isolate, to put the dam, to do deep margin elevation, but after many, many times, of course. So in our job, you can burn with a skill, yes, but if it's not, you can dedicate a lot of time day by day without ever giving up. So thanks to my office owners. And after that, which message we can take home? So I think manage the walls of the adjacent teeth before taking impression to give enough space for laboratory. Don't worry just about vital or no vital tooth, but look at the structure and how many walls and which thickness of them. The horizontal preparation makes impression taking easier without misunderstanding with dental lab. So you can bond on deep margin elevation, provided that the dam was used, of course. And don't use the horizontal preparation, I think, in aesthetic areas in the buccal zone because the difficulty of hiding the line is considerable. So thanks again for your attention and your patience, even it's very late. So thanks, Dr. Hassan and Dr. Sadir. It was a pleasure being with you. And if you have any question, I'm here with you.
Habibi, thank you so
Habibi.
much. Man, I feel jealous from your preps and from the lab also.
Thank you.
have a
Thank
good
you,
lab
Roxanne,
here.
Stefano.
I'm dealing with a good lab here, but your lab
Yeah,
is insane. It's a little bit insane.
of course. We work with the team.
Yeah, this is the point. So, Sadir, please join us. I'll start with a few questions for you, my brother, okay? There's some questions that have been dropped off in the conversation, okay? First of question, the last question was mentioned here, why not Dowlicure? Why prefer composite? Dowlicure cements, why you prefer heated composite for cementing, for bonding?
Yeah, in my opinion, I prefer composite, like I said before, because if you have any gap to fill with composite, you can do it.
Yeah.
And mainly, I think when I cement an overlay, I want to have time. I want to have no stress because the cement convert. So I want to take my time, my seconds, my minutes, and I want to stay relaxed.
Yeah, so it gives you more time. Plus, also, I think there is one of studies that mentioning that there is much better marginal integrities or marginal stability for composite better than the Dowlicure.
Yeah.
So yeah, it's much more stable. And plus, you mentioned very important point. It gives you like a free time, like almost unlimited time for work. So this is very important. This is very important.
Yes.
Thank you so much. So again, another question for you, Tommaso. Okay, which composite for the IDS? You seal the dentine always. You don't leave the patient to leave without IDS, right? So what type of composite do you use for IDS?
I usually use the bulk composite, or I usually like to use the omnichroma composite. I don't know if you use it. because of the chromatic ability to stable ability. And
Okay.
because when you warm it, it's very flowable. It's just like a flow, so you can manage it very well.
And regarding the compressive strength, the memory thing, you know, I have some composite that I've used to work with. When I try to bond the restoration like an overlay, when I press it, it gives me a lot of excess. But when I remove my finger, it starts to float again.
You say right, but in fact, in the last step, when I press the final press, I use the lamp with my finger on the tooth.
Okay, you use your finger. Okay.
Yes, finger of your spatula or condenser of some instrument, but when you are ready for the cure, you don't leave your finger or your spatula or
okay. So you press the final press, then you cure.
Yes,
you don't leave
correctly.
it freely.
Yes.
Yeah. Okay. This is the void. This is to make sure that you have a very good seating. Okay. A question also. You showed me a case. You showed a case for the perforation, lingual perforation, right?
Yeah.
Where Getteberger was inserted. You remove the Getteberger. Then you start with a white composite.
Yeah.
This perforation is opening to the sulcus lingually, right?
Yes, sulcus lingually, not under the bone level, of course.
If it's under the bone, you would use what? You would use a biodentine or MTA, right?
Maybe yes. I like use the composite when I can isolate with dam. So if I can use the hook, if I can use the dam, I sure to use the composite and it will go very well and stable in time, I think.
Okay. Another question. You showed, like you said in the beginning, is very useful point you mentioned, like in the IDS. Yeah, this is light. Yeah, this is light.
Because if you see, I put the dam, and with spatula, I help me to take the control of saliva, crepicular fluid, bleeding. So I can use the normal adhesive system with etching, bonding, and composite. White because I can polish it in an easier way in the second step, of course.
As long as it's accessible from behind.
Yes, I use the insert of reciprocant handpiece, and I can go under the sulcus, and if I see the yellow of the tooth and then the white, the white of the dentin composite, I can make sure that the polish is good.
Okay, I got you. You mentioned also a very good point. I need to mention again, which is like you in the deep margin elevation cases, you always elevate your margin with a different color of composites than your final restoration.
Yes, I love do it. Always. When I do a deep margin elevation, always use white dentin composite or white dentin flowable.
Okay, you use a white dentin composite just to make you distinguish between the restoration and the deep margin elevation point.
Yes.
Okay. And also there's a question that have been asked many times. In the last case you showed with the missing lingual or buccal, I don't remember, with the last case, you showed that you one of the clumps that you have used. What type of clump is that?
In the last case, you see the okay, this one, I think.
Where's the missing buccal?
In this case, this is an sorry, the point.
This is modified to
not
12?
modified, is an anterior hook.
The same before.
The anterior hook. This part is the anterior hook, okay. And this one is a Heidemann spatula.
Okay.
So it's not a hook.
Yeah.
It's a spatula.
I got you. It's not.
Okay.
Okay, I understand.
The anterior and spatula in this part when I do the deep margin elevation, and then I remove it, of course.
I got you. Very nice, very
Yes,
nice.
this is a case, not ordinary case. Maybe the vertiprep is, I don't know,
Verti
Dr.
much
Sadir,
easier,
what do you
yeah.
think about that?
In this case, I would go with the Verti. I would go with the
Yes.
yeah. Very nice, man. Thank you so much.
Thank you, guys.
Let me ask Sadir a few questions.
First, Hassouni, I want to just congratulate my friend Tommaso for this great presentation. You have great skills. You are really capable of your technique. Thank you. You did very well.
Thank you, guys, for the invitation. Thank you too.
Man, you're amazing. Thank you. Stay with us to the end. So I have a few questions for you, Sadir.
Yes.
Okay, there is a lot of questions that happened during while we were speaking. First of all, the first question was, it's always you always need provisionals or not?
No, you don't need always provisionals. You should understand that the main reason, the main goal for provisional is just to fix the teeth. Okay, fix the teeth in place. I don't need a provisional to like shape the soft tissue or something like that. So if you saw in my case, I always keep my provisional away from the tissue. I'm talking about just ordinary cases, not like anterior cases or aesthetic cases. We may use like the provisional for some shaping of the tissue. While for most of the cases, especially the posterior one, I do provisional for cases that require a deep cutting. Because if you cut deep inside the tissue, you should wait more, you should give more time, like 2 to 3 weeks. If you raise the flap, you should wait like for a month or and a half. So you may use the provisional to stabilize the tooth in place and to stabilize the opposing tooth in place, especially in young patient, because a young patient we can expect more tissue mobility. So this is the main reason. In simple cases like shoulderless case, when I take my immediate impression, usually I don't use provisional.
Okay.
Oops.
Okay. So you try to maintain spaces. You try to prevent the tooth from migration by provisionals only. We don't need
yes. This is the main goal. Yes.
Okay. Thank you. Okay. For Mr. Tommaso, he mentioned that he's using heated composite, but for you are using GIC. You mentioned that, right?
GIC
with zirconia.
For
Yes.
zirconia.
Yeah, GIC or resin modified. You can use also resin modified.
Also, but
to be honest, for about I've never seen a case of it did happen with me of the attachment or fallout of the crown with GIC. You can use, if you like, you can use resin with zirconia and following the APC protocol. But as I said, I like to use GIC. It's easy to remove. I can guarantee zero excess, and this is what I do.
Okay. So another question also for you. There's a question that has been repeated many times. The question is, you don't make any finishing line in your vertical preparations.
This will depend on the type of preparation. In vertical preparation, we have two types of preparation. We have the shoulderless, and I use shoulderless in easy cases, not in deep margin extension. If I did a shoulderless, of course, I have an edge, and the crown will stop.
Right?
Sorry?
The shoulderless is a slight finishing line.
Yes, it's more conservative than the edgeless. With the shoulderless, you should place a margin, equigingival or slightly maybe subgingival, and if you have some aesthetic reasons, only 0.5 subgingival. This is a shoulderless, yes. But in deep cases with deep margin extension, when I have a deep decay, I use the edgeless. And with the edgeless, there is no margin. After healing, the crown will just end within the tissue. So the tissue will be the guide in edgeless preparation. And of course, you can combine it. If you have like a good tooth and you have a side which is very deep and you did a deep margin extension one side, you can do edgeless in that deep part, and you can do shoulderless on the more if you have a more structure.
Okay.
So you can do multiple type of operation the same tooth.
Okay, so no finishing line, edgeless in case very destructive, deep cases, or it's like if you want to be minimal invasive, you go for a shoulderless, which is like it's a slight finishing line.
Yeah, there is a line, an edge. The crown will end with it.
Okay, I got you. So let's make that. Yeah.
Let me make something clear. Even with the shoulderless, if you did shoulderless, and let's assume that you didn't pay much attention and you prepped so deep, okay? It's okay. Also, you can after healing. In this case, you should wait for also like 1 or 2 weeks. When you get soft tissue healing, you can finish your crown within the tissue. Forget the edge, because the edge become very deep. You should not finish your crown within the edge. You should stay within the tissue. Okay. If any mistakes happen.
Okay. So a question for both of you. Each one of you will give me his point of view. Let's start with you, Tommaso. For zirconia, usually the vertical preparation method, they prefer zirconia. What do you think? Because it's healthier for the soft tissue?
Yeah, I think for the when I usually use the horizontal preparation, because in my office I do adhesive prosthesis, I do overlays, and not too much the full crown. But I think the zirconia is a good material for posterior teeth, for the aesthetic, for the protection.
From the point of tissue, Pro, what do you think? Which one is much, if you have like a case you want to insert the finishing line deeply subgingival, which one is healthier? Which one is less irritant to the soft tissue? Is zirconia or lithium disilicate materials?
No, I think under the gum, the zirconia is a very good material.
Zirconia is very good material.
Yeah.
So, Sadi, your point of view also.
Well, there's two parts of the question. The first part related to the soft tissue, and I don't see a point of differences between zirconia and the lithium disilicate in relation to the soft tissue. I expect a good soft tissue healing in both if you handle it very well. If there is no excess, if it's not deep in the tissue, with zirconia or with even with the BFM, you can get very good soft tissue healing. And if you saw the case I shared with the POPT, he used the PFM and they get a beautiful soft tissue healing after 10 years. So it's not a matter of material. You can use what material you use, but you should take care not to go deep into the tissue, and should take care of the cement, no excess. You will have a very good soft tissue healing. And the second part, the second part about the preference between zirconia and lithium disilicate in cases of full coverage, I prefer zirconia, because when we talk about furrow, like a furrow, the crown is the furrow, and the tooth structure is the furrow effect, and we need the furrow to be more stronger than the furrow effect to protect it. Because if you have the material same rigidity, same stiffness, there is no reason from it. Okay, so I prefer zirconia in cases of full coverage, and especially in cases of compromised teeth when I have a little furrow. If you have a little furrow, I prefer zirconia, because the furrow have to be more stronger than the furrow effect.
Okay, thank you. Another question.
Also, for the aesthetic reason, I think the zirconia is better than disilicate for the aesthetic reason.
For a set, maybe it depends on the lab. If you have like a super lab like yours, no, you don't need.
Yes. Mhm.
Yeah,
I will kidnap your technician when I come to that.
yeah, really good, very good
Okay.
technician.
Yeah. So I have a few questions also again for both of you. So, but give me a number of bears, okay? Number of bears. How many bears do you need for like an overlay prep for you, Tommaso?
I really just like
Two, three,
I show you before, uh, two burrs
more than.
and then rubbers.
Okay.
Okay, so
So
two
two bears,
burrs
then
with
rubber to finish.
two burrs and rubber for finish. Yes, I
Okay.
think
And you,
you can use maybe also 10 burrs if you want to take the details, but
yeah.
the reason is what you want to explain, what you want to share with the colleagues is not to show that I use 20 burrs, 20 rubbers. So
Yeah.
I think you can do a good preparation with few burrs. So two burrs and one rubber. I think it's
Okay.
good.
And you also use disk to adjust the adjacent to make like a good space with a broad contact, right?
Yes, of course. If I have
Yeah. We
to
do that
touch
also with the class
the
too. Yeah.
adjacent tooth, I have to use the reciprocant handpiece. I have to use the disc, but for the preparation of the tooth, few burrs.
Okay. So two bears and the third for as a rubber.
Yeah.
Dr. Sadir, how many bears do you use for vertical preparations?
Well, like the same. I use the butt bear for egg reduction, and another bear for the occlusion reduction. Because with the butt bear, you can't do occlusion reduction because of the blunt end. So mainly also two bears: the butt bear for egg reduction, and whatever bear you would like depth cut or something like that for the occlusion reduction. So mainly two. Of course, you should finish all the margins with discs or whatever you like, but mainly two burrs.
Mainly two bears. The same story. So again, another question. For you, I have asked you this question, but to make a comparison. Tommaso, my friend, you always seal the dentin, IDS, okay, right? You always seal
Mm-hmm.
the dentin. As long as you have exposed dentin, you
Yes.
always seal it with a
Yes.
compost.
To
You
avoid
told
the
me it's
sensibility.
omnichrome, right?
Sorry?
You told me it's omnichrome for IDS or a flowable.
No, for I guess I use the flow ball.
Okay.
I use the flow ball.
Then for bonding, it's omnichrome.
Yes, exactly.
Okay.
Exactly.
Okay. I will use omnichrome. I will put it in my mind. Thank you.
Yes.
And for you, Sadir, you don't need to seal the denture, right? If it's a vital tooth.
If it's vital, you should seal it if it's vital. It's also according, of course, to your type of preparation, how invasive you are, and of course to the amount of dentine you exposed. But with vital teeth, you should use temporary as well, and to protect the dentine, and you can do IDS
Okay.
also.
Okay. Thank you. So the last thing, from the point of time, guys, both of you, Tommaso, like a case with a deep mesial cavitation, okay, you need to do deep margin elevation, you need to do IDS, then you take impression, then you need another appointment to make the bonding of your restoration. So
Yes.
how much time do you need for the first session, and how much time do you need for the bonding?
For the bonding is almost the same for each teeth, for every teeth. So I think 40 minutes is good. 40 minutes, 45 minutes.
45 minutes
Because
for
for
bonding.
bonding, yes, because I want to put the gum, to take pictures, and to do everything's good, and maybe polishing later, and control the occlusion. So 45 minutes is good. For the
Okay.
preparation, it depends, because if you have a no vital tooth with no deep margin elevation, I think you
Happy life.
don't need the time for anesthesia, for example, 5-10 minutes for anesthesia. So 30 minutes, it's enough. If you have to manage a deep margin elevation in a vital tooth, maybe in the molar mandible tooth, 1 hour, 1 hour and 15 minutes, I think.
So you put like 45 minutes for bonding and almost 1 hour for the first session if you have.
Yes, yes, and they love to, and they like to do in one appointment. So deep margin elevation, polish, preparation, and taking impression. Not in too much appointment.
Okay, got you. 2 appointments is more than enough. Okay. For you, Dr. Sadir, how much time do you need like for elevating one margin with a freehand technique that you have shown? And how much time do you need for the second visit?
Well, it's according to the case, of course, but maybe for the case I show you, it's a difficult case.
Let's say one tooth. Let's say one tooth with one mesial, with one side.
One tooth will maybe after isolation, you may take like 50 minutes for isolation and the anesthesia, and 50 minutes also for the build-up, because I don't use any mattress. I just do bonding and freehand build-up, so I don't take so much time with it. And for the preparation also maybe like 5 minutes for the preparation. For one tooth, it's enough for the preparation. So for one tooth, 40 minutes is enough. 40 minutes is good. And I'm talking about a difficult case, a very deep case. Okay. And for I do cementation, so it's just 15 minutes would be very enough for me.
Okay, 15 minutes for.
I don't do appointments for the second visit for the cementation. I only cement the cases between my appointments. I don't do one appointment for cementation. And you can understand how much time I need. It's just like from 10 to 15 minutes is enough.
Okay. Great time. Let's finish with the last question for Tommaso. Tommaso, the proximal area, when you bond it, do you polish with strips?
Yes, I usually not use matrices, or I press my overlay, and then I use the floss to get away the main excess, and then I use the but you mean late after bonding or
after cure?
Sorry, after cure. So yes, I use the reciprocant handpiece, Eva handpiece. I don't know if Eva handpiece, you know. Okay, and the strip, yes, of course, the paper strip.
So you use the thin strips to polish at the end.
Yes, and but mainly instrument is the reciprocant.
The reciprocant. Okay.
Yes.
Which brand do you have? Do you have this one, the Eva that you mentioned?
Yes, Eva from Cabo.
Eva from Cabo, yes.
Yes.
Yes, I know.
Perfect instrument. Yes.
Okay. Guys, thank you so much. Thank you for both of you. You showed a very nice 2 techniques. Each one of them has its indications, and each one of them can show a great results if it's like being delivered by an expert dentist like both of you guys. Thank you. You are very close friends. You are very amazing dentists. Love you both, and thanks for being with us. No, thank you, man, Tommaso.
Thank you.
Next week, right?
Thank you for you, my brother. Thank you.
Can't wait to see you in Milan.
Can't wait to see you, man. Okay. Thank you, guys. Thank you.
Thank you.
Have a good night.
Have a good night.
Thank you. Have a good night too. Bye-bye. Bye-bye.